will be able to see this presentation in the YouTube channel, as Firas will be posting this later on. As I said, my name is Amjad Madani. I'm based in Ireland, in Dublin, and your presenter will be Omer Zubair. Omer is one of the most recent orthopedic FRCS intercollegiate exam passer. He achieved this in April, and he is one of the candidate or one of the mentors in the FRCS group. He's working in University Hospital in Birmingham. His talk is mainly around about the osteotomies around the knee, and I cannot emphasize how important is this topic. And Omer, you are online.
Sorry for the delay regarding this presentation startup. Okay, so I'm going to focus on the topic of the osteotomies around the knee, as Amjad has very kindly introduced me. My name is Omer Zubair. I currently work in University Hospital of Birmingham. And yeah, next please. So I gather that most of us do have some basic knowledge about the osteotomies. It's a very important topic in the sense that we sometimes ignore this topic when we are preparing, but it's an easy topic if it comes across to you guys in the exam. So let's start. Osteotomies around the knee, it's an old concept. It was introduced in the 60s, and a lot of people were doing it. There was a lot of data published in those days, but then with the advent of the knee replacements, total as well as the unis, this topic got out-fashioned. People shied away from this topic, and they were not doing that much. Hence, it was not popularized up until 1990s, when this concept gained another reappreciation by the, especially by the work done in the European centers. And that's how the topic got introduced. And a recent Royal College suggestion regarding this concept has included us to be a part of this discussion. Now, going back to the discussions, as we all know, its most common indication is the isolated medial knee OA, and I have intentionally put the tibial malunion. I will come back to this particular reason in a second, especially at the end of this discussion. You will see why it has been put it. Ligamentous instability, more specifically the varus instability, or the osteochondral lesions, or the osteonecrosis, or the all various indications to perform the osteotomies around the knee joint. Could be intra or extra-articular, or could be combined. Intra-articular always challenging, as we all orthopedic surgeons know. Anything involving the joint is difficult, and extra-articular is taken as a relatively easy option, though it's not always. And there are various techniques. Amjad, next please. Going back a little bit to the tibial malunion, as I mentioned in my previous slide, the tibial malunion is very specifically related to our discussion today. A brief background knowledge of malunion, which I'm sure all of us know, is a healing in abnormal position. It could again be intra or extra-articular. It could be a combination of both. The most important bit over here, which you guys have to keep in mind and obviously express this particularly in the exam, is that it can cause angulation, rotational component, translational element, as well as issues with the length. And it can cause pain, deformity, functional deficiency, and arthritis in the long run. I won't emphasize any further on this tibial malunion, but as I said earlier, we will come to this point in the end. Now, you got a patient which has got medial sided knee osteoarthritis. How are you going to assess it? The first thing in the exam, I will obviously mention about taking a history. And in the history, I will be talking about the pain. Now, I can't emphasize any further about the element of pain in this regard, because if someone comes to you with a mild bit of pain, which is well controlled with analgesics, or the pain is not stopping the person doing his activities of daily living or his profession or his any other activities, that knee symptoms are not worth any surgical intervention. So you have to make sure that either the examiner is in giving you the indication that the pain is bad enough, or you are showing it to the examiner that you want to know that the pain is bad enough. Obviously, you need to know about the past medical history, social history, smoking, very important, as you will be aware of the fact that most of the osteotomies are breaking a bone and then letting it heal. So smokers' bones do not heal very easily. And patient expectation, that is another important element of our assessment. Someone who is expecting to go back to his very high level of activities, or someone who is not able to tolerate a bit of pain, is not a very ideal candidate for these kind of procedures. After taking history, I'll focus on my clinical assessment, which would involve limb assessment. It's a generic term which will obviously involve almost everything that you can think of about assessing a limb: the length, the rotation, the angulation, any problems with the joints above or below, any arthritis anywhere else, the strength, the neuromuscular, the skin condition, or any vascular issues. Next is the radiological assessment, which is appropriate radiology. That's the buzzword that one needs to say over there, which is the x-rays. And x-rays could be stress view x-rays. Obviously, the baseline x-rays are the AP, the lateral, the skyline views, CT scanogram, and MRI scan to assess the extent of the joint involvement. So once you have made a brief assessment of how your patient is looking like, then obviously we'll proceed to our next step. Yeah, I'm good. Next, let's focus on the bit of the basic concept, which I would take it as a bit of the in-depth knowledge of what we are talking about. So for someone to be aware of the center of the femoral head is taken as the center of the hip, center of the knee is the midpoint of the line connecting the two spines, the medial and the lateral tibial spines. Central of angle is obviously the tibio-talar joint center as well, which is the midpoint of the talar height as well as the width. And the mechanical axis versus anatomical axis of the femur and tibia, a very basic concept, which I'm aware all of us would be aware of this. And mechanical axis of the lower limb, which is the weight bearing, another name given to that is the weight bearing line. And we will come to it in the next few slides. We have got some pictures where we can very quickly go through these basic things. Yeah, I'm good. Next, please. So here we can see, for recapitulation, the lines which are drawn from the center of the head to the center of the femoral head to the center of the knee, and going all the way up to the tibio-talar joint, and the anatomical axis, which are through the anatomical axis are the lines going through the shaft of the femur and the tibia. Next slide, please. There's a bit more information in the coming slides, which you can see. Mechanical axis is a very commonly asked concept, which I myself was asked, and a very simple, straightforward definition: a straight line from the center of the hip to the center of the ankle, and that is the weight-bearing line. It is equivalent to the weight-bearing line. All our discussion is just passes through the center of the knee. That's the normal bit, but we will find a lot of variations. Different studies have given us different values, and obviously pathology is the abnormal version of the normal thing. Just a diagrammatic thing of how you calculate, how you assess the anatomical axis: tip of the greater trochanter to the center of the femoral condyle distally. Mechanical axis is center of the femoral head to, again, the center of the knee joint. And as far as the tibia is concerned, both the mechanical and the anatomical axis are so close to each other that they can be reciprocally taken as one line. Next, please. Now, that's the long leg views, which is, as we mentioned earlier, appropriate investigation. So this is part of the appropriate investigations. Just looking at the knee joint, you can never assess the true picture of the limb, the limb alignment. You need to have either the long leg x-rays, or you can do a CT scanogram to see what is the situation in terms of the alignment. And please do remember, this is the malalignment of any limb is a 3D deformity. When we do an X-ray, we are just looking at a 2D picture of a 3D object, and it just gives you an idea about the frontal deformity, which is again a coronal deformity. Looking at the lateral views gives you only the sagittal deformity, which is important, but not that important in this particular discussion. And there are elements of rotational deformity which are very difficult to be assessed or even measured or even corrected in particular surgery. Though people have tried talking about it and people have tried addressing it, but it is a technically challenging issue. Next, please. Now, going back, every one of us will, whenever we see a medial-sided knee osteoarthritic problem, we will straight away jump to the right side of the top of this slide, which is the knee replacement. And some of us will say, okay, maybe uni. And very few of us will mention about the HTO. That's why I have put it other way around. And HTO versus uni versus total knee replacement, it also gives you an idea about the age and the activities of the patient. Now, the reason that I have, to be honest, chosen this topic was a commissioning guideline by the Royal College of Surgeons in London. They have suggested that one can consider HTO in a selected patient groups. We will come to this in a bit of detail in the coming few slides. What that selected patient group is, how do I identify that the patient which I am dealing with falls in one of that selected group, and what the patient's expectation and what my expectations should be. Now, what it is just, I've just literally copied the guidelines from the Royal College site over here. There's the moderate to severe knee pain, which is not controlled by the non-surgical management, which we all know, like analgesics, physiotherapy, or the bracing. And they have put it as 3 months time, and there should be a varus malalignment. They haven't quantified it how much. Okay, someone was asking about this question, I think, earlier. And again, the level of arthritis, grading of arthritis should be grade 1 to 3, and it should be unicompartmental. Though there is a talk about having arthritis in the PFJ area as well. We will come to it because there are some studies which address this issue, saying people have done in people with the PFJ-OA, mild PFJ-OA, and they have got good results as well. And the most important, young patient. We will come to this a bit as well, that what is the definition of young patient. And again, just to summarize that, the basic technique over here is we are actually trying to unload the medial compartment, which is the diseased compartment, to reduce the pain and delay the TKR. So this was the one line which I think can make a huge difference when you are sitting in an exam, so in front of the examiner. If you say this single line sentence, I believe that conveys a lot about your thought process going on regarding the management of a medial-sided knee arthritis in a young patient. You are unloading the medial compartment, you are reducing the pain, you are not eliminating the pain, and you are delaying the TKR, you are not avoiding it altogether. So that means when you talk to your patient, you tell them, I am reducing your pain, but I cannot cure it. You will have some element of pain. And I'm delaying, this is a time buying measure only. I cannot promise that doing this procedure will give you a lifelong relief from arthritis or from your symptoms. You will need at some point knee replacement. And there is no good comparative, to be honest, there is no good comparative evidence available to suggest HTO is better versus uni is better versus TKR is better in young patient especially. So that's why I have mentioned this thing. Okay, next please. So when you are planning an HTO, obviously you have done your basic workup, which I've put in the next slide as well. So first of all, you determine the Fujisawa point, which we all know is like 62%, or some people say 63% of the tibial plateau width. You start measuring from the medial aspect and keep going up to the lateral side, and wherever you reach up to the 62% mark, that's the Fujisawa point. There are different methods. Some people have tried to different methods of assessing the Fujisawa point, which is the point through which your mechanical axis should fall after doing this HTO. That's the target that we are trying to achieve. Some people have said that we can use mechanical axis and it should be within 3 to 5 degrees of the mechanical axis. Some people have talked about doing an osteotomy and then target is taken against the anatomical axis. You're making it an anatomical valgus angle about 8 to 10 degrees, and you are trying to put the weight bearing line through the 62 to 66. Various studies, if you just quote a number, there is no the number, there are various numbers. So one of these numbers, or even just saying that you are aware of what is Fujisawa point, should be more than enough. And another important aspect we need to be aware of is the joint line obliquity. If someone has got a joint line obliquity, the procedure becomes quite complex, because HTO does involve a bit of joint level change. We will come to it in the coming slides. So the short message is, if there is joint line obliquity present, preferably don't do tibial osteotomy of any kind. Next, please. Now, so someone asked about some question about when you do the CT or the arthroscopy earlier. Generally speaking, when I'm doing a workup, I will prefer to start with weight-bearing AP, lateral and the skyline views. I don't need to, I think, go into the details of this thing, that why and what is the relative importance of all these three views. Whole leg standing views, as we know. We have already talked about stress views. Someone has got arthritis. You cannot forget the fact that you may not know, a patient will never tell you, that the patient might have had any ligamentous injury in the past, which has given him all this problem. Patellar height, because doing all this procedure does alter patellar heights to some extent. Various studies have shown that patellar height, whatever kind of procedure you do, patellar height does alter. So if someone has already had a pathological patellar height, patellar bar height specifically, that patient is not a good candidate. Okay, and tibial bone varus angle. This is a concept which I myself was not aware of till I went to the exam. So that's an angle which we will come to it, and it's more specifically important in Asian population for some reasons. And obviously, MRI scan and arthroscopy are possible options to work up if you are suspecting signs of disease affecting the other compartments other than the medial compartment. Doing arthroscopy is always an option. You can do it on table before planning, or as part of your workup preoperatively. You can. Some people like doing the arthroscopy just to map out the lesions and to see if there is anything else that needs to be done. No, I won't do the stress views under GA. Okay, now that was the tibial bone varus angle. So what is the tibial bone varus angle? It's the angle between it's the difference between the epiphyseal angle, which is represented over here in the yellow line, and the red line is showing the mechanical axis of the tibia, which again, as we said earlier, that in tibia, anatomical and mechanical axis, they overlap so closely to each other that they can be taken as one line. So normally this is about 5 to 6 degrees of the value, and the importance of this value is that measuring this angle gives us a lot of information about my cure of the symptoms. Yeah, next slide, please. So there was a very good study which was from States where they have shown that if the tibial bone varus angle is up to 5 degrees, more than 5 degrees, then you can literally say that doing an HTO will correct this problem. It's usually a congenital problem, and it is one of the reasons one of the indications where we can use the HTO to address the joint line obliquity. But again, if someone has got a very severe kind of deformity where they tibial bone varus angle has gone up to 15 degrees, that much deformed proximal tibia is there, then it is kind of a palliative treatment. It is not curative. So that means there will be some symptoms left because you can never achieve a better correction of the angles. Next, please. Now, this slide I will put as the gist of all our discussion today. This is the International Society of the Arthroscopy and Sports Medicine paper, where they have they published this in 2004. I knew this thing. I never knew before my exams that this is an ISAKOS guideline, but someone has told me in a different way, and I literally spoke for a few minutes on this particular table in my exam, and I think that helped me a lot. So as you can see, they have divided the patients into 3 groups: ideal, possibly ideal or possible groups, and people who are not sure. So you can say this is the indication versus contraindications versus the gray zone in the middle, where you may or may not do. So isolated medial low, we'll very quickly go through it. Moderate osteoarthritis, age 40 to 60 years. Though in Scandinavian people, they have stretched it across to 70 years, and I have seen some papers where people have done and are still doing high tibial osteotomies up until 70 years of age. BMI, very important, less than 30. Having a high BMI, big no for any kind of osteotomy. Again, this is a procedure for high demand people who high demand because of any reason, because of their profession, because of their leisure activities, and malalignment is not severe, less than 15 degrees. Again, tibial bone varus angle up to 5 degrees is good, but as we saw previously, you can go ahead and do it if there's a bit of deformity up to 15 degrees, but you have to tell the patient that we will not be able to achieve much. There should be any stiffness, full ROM of the knee joint. No cupula. I understand everyone should be aware of this. That's the lesion which people get with the ACL injuries, deficient ACLs. Obviously, ligamentous balance should be good, which means all the ligaments should be working fine. Non-smoker, I think I should have highlighted it much more, because this was a question which was very specifically asked to me in the exam as well, that the patient is smoker, what you're going to do. And last but not the least, your patient is happy to take a bit of pain. So the patient has got pain tolerance. You tell the patient this procedure will never cure your symptoms 100%, can't quantify it 60, 70, 80%, can't give you a number, but the long story cut short is you will have an element of pain. If you're happy to accept, yes, this is a procedure for you. I don't think I need to go into further all this guidelines. You guys can have a go through it later on, and it's self-explanatory. So yeah, how do we do the HTO? There are various methods described in literature. Various procedures are performed. I think most of us are aware of the medial opening versus lateral closing osteotomies. I have seen most of the European papers, they are suggesting about lateral closing osteotomies, though recently people are more aligned towards the medial opening osteotomy because of the better metal work which is available. Dome type osteotomy is another kind of osteotomy which is complex, not very commonly done, and again, not very commonly asked or expected to be known by the candidates. Now, if you do a bit of PubMeding, you will see every technique has got good short to mid-term results. So there is no technique which is superior than the other. So as a surgeon, whatever I'm comfortable doing, I will do that. In my opinion, the answer should be. So what is the most important predictor? You are not doing the osteotomy for a very little deformity or a very severe deformity. So if everything is little bit bad, there's no point doing it. Or if something is very severely bad, I mean, level of arthritis, pain levels, or obesity, then obviously you're not going to do this procedure. If you talk about the numbers, it's when you are creating the valgus you're trying to create about 8 to 10 degrees valgus to the anatomical axis. And if you want to measure it from the mechanical axis, it's about 5 to 8 degrees. Again, it's a number. You don't need to remember the exact numbers. Even if you just say, I will try to create a valgoid knee, that is acceptable. Few degrees of valgoid knee, in my opinion, that is absolutely acceptable. Yeah. Next, please. So now this is something, if you want to know about, if you can remember, fine. Otherwise, just read it and forget it. There was a paper, there's a big, actually, it's a quite long follow-up. It's a randomized control trial done by this Agnes Kirschner, where they have done the dynamic loading before and after the HTO, and just to see when people are doing HTO using various techniques, how much the weight is transmitted from medial to the lateral aspect. We all know that most of the weight passes through the medial side, and less amount of weight goes through the lateral aspect of the knee joint. So doing osteotomy and then measuring it, they found that the most important bit over here is the most important combination, the most successful combination was opening wedge osteotomy and making sure that post-op the mechanical axis is passing through the Fujisawa point, and you have done the MCL release. It's a superficial MCL that we release. The people say 50%, 60%. I don't know the exact amount, but just cutting the MCL. So those were the people when they were tested in the labs. So it was a cadaveric study. It was not a study. So these were found to have the maximum amount of load transmission from the medial to the lateral, who have had these 3 targets achieved or performed. And again, another important part over here is slope correction. ACL deficient knees, we all know, we tend to decrease the tibial slope because of the tendency of the tibia to translate anteriorly. ACL is the main restraint in terms of anterior translation, and the right opposite is the PCL deficient knees, where you try to increase the tibial slope. And doing the osteotomies, you can control the tibial slope. But again, it is a controversial issue. If asked in exam, I will just say, I'm aware, increase the tibial slope if deficient knee. Okay, next please. Now, what exact technique you want to use? All you need to know is that there are some techniques available: medial opening wedge, lateral closing wedge, or a distal femoral. There is nothing more than that you guys need to know. Pre-op workup, there are 3 different schools of thoughts: Coventry, Noyes, or Miniaci. Everyone has got their own ways of doing it. Now people have developed softwares. I'm aware of a software which is developed in Cumbria region. Anything you say in the exam is fine, as long as you can say that this is a kind of workup which is actually the calculation of the angles, how much angulation you need to correct to get a better result. Benefits of, there are different benefits of medial opening wedge or the lateral closing wedge or the distal femoral, which you will see in the next slide, please. Next slide, please, Amjad. Just summarize the benefits of lateral closing or the medial opening. As you can see, obviously lateral side, we are always scared of common peroneal nerve sitting very close. You have to do the fibular osteotomy. You have to literally dislocate the tibiofemoral proximal joint, and people can have issues in the coming days. Tibia becomes shortened with this technique. But the good point, the one point is that it's just a uniplanar. You cannot correct the deformity in the multiple planes. So okay, well, we'll come to this point, and then you do these measurements preoperatively, not intraoperatively. Now, medial opening wedge. Again, whether do we need a bone graft? Again, a lot of debates about it. Do we need to use a bone graft, or just leave it alone, or just put some bone substitutes? Every technique has got their own pros and cons. There is no level 1 study showing that one is better than the other. Again, you can use either a 1 saw if you want to correct the deformity in a uniplane, or you can use 2 saws if you want to correct the biplanar deformity. Slightly better in terms of it gives you the uniplant, the coronal, the frontal deformity correction, as well as control the tibial slope. But the bad side is you need a really strong fixation construct, which was the reason that people initially shied off from medial opening wedge, because the constructs were not strong enough. They were not able to take the weight. People have to stay for a long time non-weight bearing, and that created problems of their own. But these days there are new constructs available which are giving good results and allowing early weight bearing as well. Next, please. Now, when the discussion reaches to this level, I'm sure you will yourself realize that you have already passed the exam. If you are asked, okay, what kind of fixation you're going to use or how it works, we all know it's a microabortion that we want across the splinted zone. Various techniques, historically people have used casts for this purpose as well. X-fixes, staples, fixation plates, angle stable implants, which are very popular these days, or even some people have used the bone graft or bone substitute as a kind of fixation method aid rather than a true fixation method. Everything has got its own pros and cons. Pretty simple things, you know, the cylinder cast issues. I don't need to go into that detail at this level with you guys. X-fix or staples, everything has got. In the exam, I was asked, okay, what implant you gonna use? I knew just one name, that was Tomofix, and I just said Tomofix. The examiner did laugh and he asked, why Tomofix? And the answer to that is, it's rigid, it's long, and it has got the benefit of locking bolt, and it gives you too much fixation, hence it is more stable. That's the only thing you need to know. Now, other osteotomies have been described, just need to know the names. Distal femoral, usually done, or rather the only indication is in a valgus knee, where you want to convert the valgus into the varus knee, and here the purpose is to unload the lateral side. Again, the concept is the same, just reversed, that it restores the weight bearing line to neutral or a bit of within 5 degrees of the anatomic valgus, and it is converting the tension side to the lateral aspect, which has been reversed in the first instance when it becomes a valgus knee. Now, again, same principle of high tibial lateral closing or medial closing is applied to the distal femoral as well. It'll be lateral opening wedge distal femoral osteotomy is better than the medial closing wedge distal femoral osteotomy. These days, this is the latest studies have shown that most of the studies have shown that the lateral opening is better. If you have to do, then that is the option. But again, there is very limited literature. Very few people have done the medial closing wedge in the distal femur. Most of the people, they only do the lateral opening wedge osteotomies. And if you're doing very well, you can say the word, I will follow the Pellé's principle, which is in the frontal plane, you try to address the anatomical and the mechanical axis, and in the sagittal plane, you only address the anatomical axis. There's a big book written by this gentleman, Pele, and I don't think it's at our level to discuss, or we need to discuss at this. Now, complications, general risks, which you just mentioned about any other surgery that you do, and you say the general risk of all this infection, injury to the nerves or blood vessels. Specifically speaking, non-union or malunion, fixation can be lost, loss of fixation. Patella height can be altered. Even patellas can be subluxed. People do come back sometimes having issues with their patella. They were having a nice patellar tracking, but surgeon has done an osteotomy, which has healed as well. But now the patient has developed anterior knee pain, as well as he's not happy. Bone stock can be reduced, obviously, when you're doing the especially if you're doing the opening wedge osteotomy. The bone stock is not very good if you want to do the knee replacement in future, and it becomes a difficult knee replacement if you need to do one. Next, please. Okay, last slide. I'm just don't open the next slide, please. Okay, this is the last slide. Take home message. This is a simple exam, so guys, please keep it simple. When I was asked about this, but obviously you will not be asked like, okay, what do you know about osteotomies around the knee? The exam will never ever be a straightforward memory exam. You will be given a picture, so whatever knowledge you have to apply to that. And even if you have got a very superficial level of knowledge, but if you're applying it, sure you will pass. I still remember it said in the beginning in the letter that FRCS is about the breadth of the knowledge rather than the depth. So, and I believe in it now after going through this. It's an exam of your thought process, how you're thinking. It's not an exam of the nitty-gritty. It's not the exam of the technical aspects. It's not an exam of how confidently you can do a procedure which no one else can do in the region. It's just an exam of a very simple technique, which is safe. And to do that, you have to practice. I will stop here.
Let's go to the questions around the chat box. Kindly, you answered one of them. Atif was saying that, what is the rationale of CT scan? Do you want to answer again?
Yep, go ahead. Open the mic, please. So Atif, the rationale doing the CT scan is it's a CT scanogram that gives you more detailed information about not only the alignment but also the rotation. Because a lot of times, and I'm sure you might have come across this scenario, that we do the long leg films and people, they stand in various directions, in various positions they want to stand, and it gives you a very bluffing picture. Because I myself came across this kind of scenario where we sent a patient for a long leg view and he was standing in a position, whatever position he wanted or he felt is comfortable, and the picture was so much falsely benign looking. And then we sent the patient back for a CT scan and we got the real measurements, which were like quite different. So but sometimes if you are happy that the patient can stand in the proper way and you are happy to have your measurements on the x-rays alone, fine, don't need to go for unnecessary radiations. But CT scans are preferred. And again, in the exam, I think you need to say this word, that I will prefer from this particular reason.
And another question from Muhammad, he says that how much the degree of correction and how we calculate it. I think you went through this.
Yeah, I think we went through it. So again, as I said, you don't need to remember the numbers. If you just say 5 to 10 degrees, though they were, now the question is where about you are calculating those 5 degrees from. So what is your reference point? So it will just open a big discussion topic. That, okay, I'm measuring it from the anatomical axis. No, I'm measuring from the mechanical axis. Okay, then again, the question, if someone tries to ask you questions, there are a lot of questions you can have. How do you measure that? What is the best way of assessing the mechanical axis? How do you do it? And then you check, there are a lot of other things. I don't think at our level in the FRCS, any of these things. Let's say I'm going to within like 5 to 10 degrees of the neutral axis, the weight bearing line.
To assess how to assess the arthritis in the lateral compartment and patellofemoral joint, would you score?
Yeah, I mean, as I said, if there is a suspicion, again, scoping means an intervention, which obviously you have to put the patient to sleep, and then I have just put it as an option. The better thing is MRI scan. I'm sure all of us are aware that whenever we are having a suspicion or when we are trying to map out the lesions, it depends. If we are trying to do say like someone has got an osteochondral necrosis or someone has got an osteochondral lesion and we want to do something about it, then obviously scoping is better because you may go debride or stabilize or do some procedure on the same time. But if you're thinking about HTO, then MRI scan is better. The options are there, so you just have to use them according to the need of your patient.
Okay, and would you do stress views under GA?
No, I'm not aware of any. We don't. I mean, if someone has got instability, you can do a simple ball test. I mean,
would be very like you need a very good radiologist to kind of. But usually you do it well. to be honest with you, you don't need like a GA for stress use. Just you do it.
No.
In the radiology department. Now, how could I increase the slope? The technique, I mean the
Okay, so intraoperatively, what people do is they do the osteotomies are done in the true plane. The first osteotomy is done as a horizontal, and the second osteotomy is done at a slight angulation. And that second osteotomy for the medial opening wedge osteotomy is the one which controls your tibial slope. But as I said earlier, I have some serious doubts that anyone would be asked about this. I mean, yeah, you can be asked if you're doing very, very well. You could be taken to any levels. But I'm very happy that someone has asked this question, because I was thinking about giving a message earlier. I calculated, I faced 32 scenarios during that 2 days of examination, which are all of us face. So knowing about 32 topics, if you calculate, it's literally impossible for everyone to know all these minor details of an individual procedure. Again, a procedure which is not done very commonly in our day-to-day life. Even one of the knee fellows here, or a sports fellow, I'm sure they even don't do more than 20 or 30 in a very big, busy sports injury center, leave alone the people who are working in DGH. So please do not go into the minor details of things. I was looking into the previous threads, and I myself have been part of this Telegram group when I was studying, and other guys were helping us out by guiding us. A lot of people asked a lot of questions, and I don't think they would have helped them in the exam. Trust me, exam is all about knowing the basics, playing safe, showing them I know my basics, I know my limitations, this is where I stop, this is where I refer, this is where I seek help from my other colleagues, and I know the theoretical things.
I couldn't agree more, Omer. I think it's very important to emphasize on, like, what in your one of your slides is saying that the principle of the treatment. But before passing my exam, I was making sure that to say this phrase, the principle of the treatment is to do this, to do this, to do this. And here, like you said, the principle of the treatment is regarding the micromotion of the bone. So that will kind of get the examiner on track there. I don't think this exam is about details. So the devil is in the details in this exam. Omer?